started with laparoscopic cholecystectomy, the robotic cholecystectomy, since we had immense experience of laparoscopic procedures. We just felt it will orient the team better, and then we move on to the next one. We have expanded the team since then, and we have done extended array of procedures, but it has been a iterative process. Every time we would do a new procedure, we go through a planning exercise, we perform the procedure, we have a debrief after every procedure where we see what worked, what didn't work, we make adjustments or the action plan for changes, then we go through the next procedure. It includes the information about the procedure setup, especially with CMR robot. The arms placement is important along with the port placement, troubleshooting for whatever can happen, and then technique alteration as required. It has been a difficult process to start with, but we have worked together and made headway, and we intend to keep making that going forwards. This is our data from August this year. Till then, we had done around 150 cases. We have done 8 different types of procedures, but that included hemicolectomies, APR, low anterior resection, gastrectomy, robotics, hepatic cyst, endocystectomy, and then hysterectomies, along with the bulk of procedure, which were cholecystectomies and hernia repair. For this learning curve exercise, our research question it was to assess if our skill for performing robot-assisted transabdominal pre-peritoneal inguinal mesh hernia repair has improved during the time. It's interesting because this is not the procedure I'd done prior laparoscopically. I am used to doing extraperitoneal repairs laparoscopically, but I never did transabdominal procedures. So neither did my partner. So it was an interesting. So when we moved on from cholecystectomy, we thought that we will start with a procedure, a robotic procedure, which we are not used to doing in a certain way laparoscopically. And then we proceeded with that. Before any more description on that, let's just go through the dynamics of what a learning curve is. We all are aware of the learning curve in general. The principles, as we understand, is that got experience with learning or skill acquisition. It has 3 phases. The first phase is the lag phase, where you, with the experience you are learning, your skill acquisition is slower, and then there is an exponential phase, but it is much faster. And then there is a lag phase where you have reached the expert level, and the increments are slower. One of the important information coming out of the learning curve is how many procedures, for example, we need to do before we reach that expert level. We all know that tasks require less time and resources as more of it is performed. The adage, as we have all heard in our childhood, practice makes perfect. This process actually started in 1885, formally as a scientific research. Ebbingus, a German psychologist, looked at how people learn new things, and then he came to a conclusion after experiments that when learning a new procedure, performance tends to improve with experience, which is very intuitive, but this is what he found. And some 50 years later, this was applied to industry by an aeronautical engineer who, from their practice, learned that speed or efficiency of airplane component production increased and cost decreased as the experience and skill of the workforce increased. It took another 40 years before a medical person retrospectively reviewed data of their specific set of procedures and concluded that a possible relationship between volume of clinical work and the outcome. So very simply stated, learning curve is a visual representation of how long it takes to acquire a new skill. It usually relies on a set number of procedures performed, or duration of procedure, or the time over which the procedure performed, and then we can actually compare it to any outcome measure, but mostly it is done, for example, with the average time taken, or the outcomes, as we will discuss more. Here an important question to consider is how do we measure a skill? And also, how do we determine that a skill has been achieved? Because a skill usually constitutes a complex set of maneuvers. Number of times it's difficult to actually assess the acquisition of a skill directly. It's like, for example, a salesperson, how do you assess their skill for sales? Usually you use indirect measures for that, some key performance indicators, some metric, some goal that indirectly reflects expertise in performance of a task. In industry, for example, this would be production time, the cost, the quality control. In business, it would be like sales, the customer satisfaction, the market share. It is even more difficult when you're talking about clinical performance or surgical performance for that matter. And we do rely on surrogate measures. There are two types of surrogate measures generally in vogue when we are talking about surgery. These are surgical process measures like operative time, the blood loss, the technical adequacy of resection in cancer surgeries, like the margin involvement or the lymph node yield. And the outcome measures would be something like analgesia requirement, the transfusion requirement, duration of stay in the ICU, length of stay in the hospital, and so on. The surgical learning curve is very similar to any other learning curve. You'll see an exponential rise here where the skill is being rapidly gained, and then you reach the expert level. You see this dotted dip. This is where you would take on more difficult cases, or at times some laxity comes because of the experience and can lead to some suboptimal outcome. So again, the steepness of the curve actually tells you we generally tend to say that this curve is steep and mean that it's more difficult, but actually steeper curve means that you are acquiring skill faster for a shorter number of procedures performed. So it's actually a misnomer in that sense. Anyways, so in surgery in general, we assess the skill acquisition or the quality of skill or the measure of skill indirectly based on observation by independent assessors who usually use some kind of semi-quantifiable scores like OSATs, or Objective Structured Assessment of Surgical Skill score, or the GOLS, or the Global Operative Assessment of Laparoscopic Skills, or RTAP in gynecology, like Robotic Hysterectomy Assessment score. Similarly, now we have a validated score for robotic surgery, which is called GARES, or Global Evaluative Assessment of Robotic Skills. It measures 6 parameters: depth perception of the surgeon, their bimanual dexterity, their efficiency or economy of movement, their force sensitivity, their autonomy to complete the procedure, and their control of the robot. This is the score in more detail. For example, if we talk in terms of bimanual dexterity, you can see the lowest score of 1 would be someone who uses only one hand, ignores the non-dominant hand, has poor coordination, and the expert will be using both hands in a complementary way to provide best exposure. They found good internal consistency, which means that if someone is improving on bimanual dexterity, they will be improving in efficiency at the same time. And this is pretty good at nearly 90 to 93% based on Cronbach's alpha. It also was found to have good discrimination among the experienced and novice workers. Even though we had not formally studied cholecystectomy, just to give you a sense of how the graph comes about. So when we looked at our experience of cholecystectomy, that you can see the time to perform the procedure is decreasing rapidly, and still in the 9th month of our practice, we were gaining on time. This reflects differently in this curve, where we are comparing it to the procedure and we're using a different line. This is the power line. Power line is used when you have a sustained acceleration, like in cars. So you can see the blue dots, which represent individual procedures, are scattered. This is because there could be an easier cholecystectomy and a more difficult cholecystectomy, which takes more time. So that is why the R square is not grand for this, so it doesn't really fit well. So this curve essentially gives you the idea of where the average lies, but doesn't give you idea of all the procedures done. Coming back to the RTAP experience, by August, we had done 32 procedures, of which 6 were bilateral hernias, 32 hernias, of which 6 were bilateral hernias, the rest were unilateral, of which most were left, and all were males with a mean of 24 BMI, and both of these measures were normally distributed. As you can see, we had, by design, low ASA patients, because the patient had to place in the Trendelenburg position for extended time, and we felt that we should be avoiding some elderly patients with comorbids. But this is becoming laxer as our experience is being gained. All the procedures were shared between 2 surgeons. And here you see the learning curve. Here again, we're using the exponential line, the blue dots representing individual procedures, and you can see that we are making headway in terms of the duration of required to perform the procedure. And you can see this curve is not steep, which means our increments are coming slower. They're not coming really rapidly, as it was the case with cholecystectomy. This is again the same experience, but here again we are looking at the number of procedures, and we have and it's showing you that starting with for unilateral hernias, we are reaching a median of 90 minutes, which is what was reported in literature, and we are probably going to improve little, very little from that point on in terms of time needed to perform. Maybe people have better experience on that, but this is what I found from the literature. For the next phase of assessment, what we did was we segmentalized the procedure, which means that we formally divided the assessment into 4 steps. This helps assess segment. So every step has a specific set of skills required. And so it gives you the idea of what you actually need to improve upon in terms of specific skill to make changes. This is a representation of internal and transabdominal anatomy of hernial orifices. As you can see, the median and the medial umbilical ligaments and the lateral ligament, and you can see the inferior epigastric vessel coursing down. And here we have the vas deferens and the gonadal vessels. And this is left-sided hernia, and maybe a small femoral hernia as well. So this we are focusing on the left indirect inguinal hernia here. We use the 3-zone dissection as described by Dayes. And then the first step is the 3-zone dissection step, which the medial zone representing the pubic symphysis and the area around it. And this is the zone 3, this is zone 2. The zone 1 is the lateral zone, and the zone 3 is around the vessels. Once you're done with that, we move on to doing the dissection of the sac, which is most cases the rate limiting step, where you have to formally dissect it into the canal and free the sac off, bringing it back into the belly. And then the goal is to reach what's called the critical view of myopectineal orifice, again described by Dayes et al. That includes the 3 lines, that is the inferior epigastric, the vas deferens, the gonadal vessel, and the 4 triangles, the direct triangle, the indirect triangle, the femoral triangle, and the triangle of safety. Once you achieve that, we can place the mesh. And after the mesh is placed, we move on to the flap closure. So when we analyze through this graph, which is a proportional representation of each procedure, we did not go through all the procedures for the limited time we had. So this was each bar represents 1 procedure. The blue color represents the 3-zone dissection. The apricot part is the dissection of the hernial sac. The gray part is the mesh placement, and the yellow part is closure of the flap. Here again, it's important to understand it's proportional representation. So every bar is the same size, but it's and the time is presented in numbers. Which these bars, for example, look similar, but the time required here was 38 and this was 36. So what is important to understand here is that our first part of the case, that is the 3-zone dissection, has been more or less consistent, no major change there. For our second part, the dissection of the hernial sac is very variable even now. The mesh placement is improving. But again, it's hovering around 28%. And then the most improvement we have seen is in the closure of the flap, which is where the suturing skill is comes handy. So as our suturing skill has improved, so has our closure of the flap timing also improved. Then we moved on to video assessment of our procedures using the GARES tool that we just alluded to earlier. We asked independent assessors to, so we picked up one video of our robotic tap repair for each month randomly, and we gave it to independent observers and asked them to assess based on GARES. And as you can see, each bar represents one procedure, and each segment of the bar represents depth perception, manual dexterity, efficiency, force sensitivity, autonomy, and robotic control. And as you see here, as we are proceeding on the cases, the assessors feel that we have improved in terms of each of these parameters. So it was averaging around 3, and now it's averaging around 4 or 5 in some cases. We had 3 adverse events during this. One event was when the initial phase, our bilateral inguinal hernia extended over 8 hours. We started in the afternoon and we finished in the evening around 8 or something. So our anesthetist wanted us to continue post-operative elective ventilation. We continued overnight. Patient did okay later on, but just required elective ventilation overnight. And then the other 2 were related again to a very early part of the case when we saw recurrent inguinal swelling this on the 2nd or 3rd post-op day, and we were concerned that the repair had given way. So we took the patient back to the OR. We introduced the camera and were really relieved to find that everything was intact. It was essentially the sac hematomas that got us worried. All these patients recovered unremarkably following this. This is just some experience recounted. This has been done for a long time, and now we have meta-analyses available. These are 2 meta-analyses mentioned here, one with 9 and the other with 16 studies and more than 50,000 patients in each case. And they concluded that the post-operative seroma, the chronic pain, the hematoma, the surgical site infection, urinary retention, hospital length of stay, and recurrence risk ratio were comparable. But RTAP takes longer time, especially if it's done unilaterally, and the costs are significantly higher. This is another interesting study by an Israeli team who were very experienced in laparoscopic hernia repair. And when they switched to robotic hernia repair, they concluded that postoperative complication and length of hospital stay were similar. And the operative time was significantly longer. There was relatively less recurrence in robotic compared to laparoscopic repair. But the important part was that, as Dr. Jawad was also mentioning, so you have to go move on really planned well and stepwise, the step-up approach. And they also suggest that RTAP allows the buildup of a short, safe, and efficacious robotic learning experience for the minimally invasive surgeons for future more complex robotic surgeries. So coming back to the research question, has our surgical skill improved? We would say yes. Our time to perform RTAP is reducing, and according to independent observers, our depth perception, bimanual dexterity, efficiency, force sensitivity, autonomy, and robotic control may also be improving. In general, we would say that robotic assisted surgical procedure require specific understanding of its mechanics, like the absence of force feedback. And optical visualization is the prime here to enable optimized usage of best patient outcome. There is definitely a learning curve mandating improved skills with incremental experience. Repeated cycles of deliberate planning, engaged performance, critical analysis, and technical adjustments ensure improved process and outcome. I'll be happy to take any questions there. Thank you. They don't understand the done.
Can you hear my question?
I did not hear any question.
Can you hear me now?
Yes.
So Yeah, that was an excellent talk, and thank you very much for sparing time for us. The first question that's not related to the talk, as I said, knowing the Pakistani culture and you are working in an institution that is known for urology and transplantation. So how have you divided the time amongst the colleagues that they get time for their urological cases and you get time for the general surgical cases? And because there is a concept of efficiency associated with the robotic use. So can you please guide us regarding that? What's your experience and how you do it?
So that has not been a problem in general, because we are all dedicated to this institution alone. So we all just work here, and timing is never a problem. And essentially, we have divided days where we have access to the robot primarily, and the urologists have the access on other days. Till they have a bigger team, so they get more robotic time. We get less time, but it all depends on the needs. As we gain more experience, do more complex procedure, we need more space. We have, in fact, 2 working robots at the same time. So it's less of a problem in general.
Secondarily, I mean, you presented a lot about TAP repair. So having the same objective conditions working in the low income resource countries, what is the average cost in your setup on a robotic TAP, and how do you compare it with the laparoscopic TAP, or for that matter in open repair, cost wise?
So cost wise, we have a procedure based payment system to the company, and honestly, I am not really aware of the exact figure with what exact package we have for that. It is definitely more expensive, much more expensive than the laparoscopic procedure. The only reason we are relying on TAP is to gain enough experience so we can proceed to more complex surgeries. This has materialized in terms of colonic surgeries and gastric surgeries, and hopefully soon we'll be starting distal pancreatectomies. But it is essentially, for us, this is a training platform. The RTAP is a training platform for the team.
Well, thank you very much. I think we will be looking forward to your experience. I'll ask Professor Waris Farooq, session chair, for concluding remarks.
Dr. Arsalan, a nice talk. I'm Dr. Waris. We met you in Karachi also.
Yes, we have.
So you have given a very good framework for skill acquisition, and especially talking of this new technology. Probably from the forum of Pakistan Robotic Association, we should develop some form of skill acquisition form, on the basis of which we are in a position to train our residents and junior staff, and we are able to have a formative assessment. So that would be a great way to put ourselves forward. And it's absolutely fantastic paper from medical education point of view. And we are really delighted, and we would see you working on this project soon. Thank you very much, Dr. Arsalan.
Thank you.
So, first talk was absolutely a fantastic talk on HBP, and Dr. Irfan and Jawad, they have been together. And we are actually proud of our Pakistani, who is a lead team in UK regarding the robotic HBP. And I hope soon the SIUT would be the lead in Pakistan in starting the robotic HBP. And with the same words, thanks to all. And it was absolutely a fantastic session. Geared up a lot of questions and queries, and we can proceed with next session. Thank you very much.
Thank you very much, sir. The next session, we have one talk, that's a gynae session. And
thank you very much.